get around to it. Eventually.
My last pap test was normal. Ugh, and it's so uncomfortable. I'll wait.
At my age, I don't need to bother.
If something was wrong, I'm sure I'd notice.
I just don't have the time. I'll get to it next week.
Nobody in my family's ever had it. I don't need to worry.
You can always find a reason not to. But if you're from 50 to 74 years old, regular scheduled mammograms are the best way to detect breast cancer early. If you're 21 to 69 years old and have ever been sexually active, a regular pap test is the best protection against cervical cancer. So speak with your health provider today, because screening saves lives.
Well, screening for breast and cervical cancer does indeed save lives. We continue our focus on women's health issues this month. If you recall, 2 weeks ago we discussed breast cancer. So today we turn our focus on cervical cancer. Now, cervical cancer remains a huge health problem affecting approximately 1 out of every 41 women. Even though it is a preventable disease essentially, this cancer is estimated to kill approximately 8 women on a daily basis in South Africa. Now, the World Health Organization estimates that this number will increase to 12 by 2025 if nothing is done about it. So our discussion today will focus mainly on what to do to reverse this trend and then delve a little deeper into the concept of HPV vaccination. Now, we'll be guided by a guest panel that includes a specialist gynecologist, principal officer of one of the medical aids in South Africa, a cancer health specialist or Cancer Association of South Africa, the First Lady of South Africa, and someone diagnosed with cervical cancer to share experiences with us. So sit back, relax, and learn from this exciting show ahead. Your questions or views are always welcome, as always. Now, the telephone number to reach us at is Johannesburg 714-6841-6842 or 6843. Or send us a Twitter handle to use at SABC Health Talk, or simply interact with us on our Facebook page, SABC Health Talk. I'm Dr. Sello Mutaung, and this is Health Talk.
Cancer is one of the most serious diseases that affect women in the world. The disease is one of the leading killers in both developed and developing countries, including South Africa. Cervical cancer is the second most common cancer affecting women. Most cervical cancer infections are associated with a virus called HPV, human papillomavirus, which is spread through body fluids and sexual intercourse. Smoking is also a risk factor to develop cancer cells in the cervix. It is important for women to know what is normal for their bodies and to report any unusual symptoms to their doctor. It is equally important to screen for cervical cancer, as early detection improves treatment outcomes. Women are advised to see a doctor if any of the following symptoms develop: blood spots or light bleeding between or following periods, menstrual bleeding that is longer and heavier than usual, bleeding after intercourse or a pelvic examination, pain during sexual intercourse, bleeding after menopause, increased vaginal discharge. Unfortunately, in some cases, there may be no obvious symptoms until the disease has progressed to an advanced stage. Regular checkups like pap smear and gynecological examination for women could improve their lives. Women who are sexually active or older than 18 years are advised to do a pap smear at least every 3 years. Treatment for a precancerous lesion of the cervix depends on a number of factors. Some of the factors include whether the lesion is of low or high grade, whether the woman wants to have children in the future, the woman's age and general health, and the preference of the woman and her doctor.
Now, unfortunately for some, there might not be that opportunity to look at, options available, as we'll learn a bit later. But for now, let's learn about what this dreaded condition is about. And it's a pleasure to welcome our two special guests for now, Dr. Pam Pile. Now, Dr. Pile is a specialist gynecologist based at the Garden City Clinic in Johannesburg. Welcome to Health Talk, Dr. Pile.
Thank you for having me on the show.
All right. And we also have Professor Michael Herbst. Now, Professor Herbst is a health specialist from CANSA, CANSA Association of South Africa. Welcome to Health Talk.
Thank you very much for having me on the program.
All right. Perhaps let's start with you, Dr. Pile. Now, basics. What is cervical cancer? I see you have a model here. You'll tell us exactly where the cervix is and what actually this cancer is about. Yeah?
Yes, thanks for allowing me to bring my prop on stage. This is a model of the uterus. It's the entire pelvic structure of a female. The cancer that we speak of is specifically and more peculiarly confined to the cervix, which is the organ that connects the uterus above to the vagina below. It is very unique in the sense that it has a special region called the transformation zone. And this is a part of the cervix which undergoes extensive cell turnover, and because of the predilection for it having constantly immature cells and immature nuclei, the HPV virus, which is the main carcinogen or causative factor for cervical cancer, tends to colonize in the transformation zone.
Okay, we'll come back to causes and risk factors and stuff. But perhaps let's ask you, Prof, how common is this condition?
You know, sadly to say, we only have the latest statistics from the National Cancer Registry for 2011. But at least 5,000 women every year hear the words, "You have cervical cancer." And that is really a tragedy. And it seems to be the prevalence much higher, unfortunately, amongst those people who don't have health insurance. So it's about 80% of the population who are really most exposed to this health problem.
But why is that? Is it that perhaps you're not getting data from the private sector?
For years, the private health laboratories never provided statistics to the National Cancer Registry. But in 2011, the Minister of Health declared in the Government Gazette that cancer is now a registrable disease. So only once we start getting to 2012, 2013, will we really have a true reflection. But the National Cancer Registry is way behind in producing the registry for us. So we don't know the true figure for last year or the year before.
So let's come back to describe the clinical features of this cancer. How can someone know that she has cancer? How does it start?
Firstly, as we know, cancer is an abnormal growth of cells that occur in a specific organ in the body. And in the case of the cervix, it is very easy to have these symptoms masked. So to start off with, there may be a small percentage of women that may be completely asymptomatic and not be aware at all. And only on routine cytology at the time of her visit with her gynecologist will it actually be detected as either a precancerous or cancerous lesion. Sometimes it's actually seen with the obvious aided eye as well as an ulcer or as a necrotic growth.
So this is something that only obviously a trained eye, a specialist like yourself can see, or in fact even a GP or a nurse for that matter.
Or a nurse for that matter. But in the majority of women, women will typically present with postcoital bleeding, bleeding after intimacy, bleeding that is out of sync with their menstrual cycles. Often as well, in the early stages, they present with an atypical vaginal discharge. It's often bloody in nature. In the late stages, it's often associated with marked weight loss. And of course, the age of the woman plays some role as well. The older woman will probably present a little later with more advanced disease. And markedly, her weight loss will be a factor above the other bleeding symptoms.
Okay. Talk about age, Prof. Where do we see this commonly? What sort of age band?
Well, this is the worrying side about cervical cancer, because previously, we started really seeing problems around about age 30 and up. And lately we are seeing many more women at an earlier age, even in their 20s. And it creates a problem as far as access to healthcare is concerned, because we don't have a cancer control program in South Africa yet. So the rules and the regulations and the criteria are not all in place. And very often the younger women who come up and say that they do have problems, they don't get the care and the treatment and the investigations that they need, especially so for those who do not have access to health insurance. But we see younger women in their 20s now starting to show early signs of dysplasia, which is the first change in the cells that the doctor was talking about. And if we cannot do something about it at that stage, it will develop into cervical cancer at a later stage.
Okay, so you see it across ages. Just now you said you get data from the public sector, as it were. But the cases that we see, what is the sort of socio-economic or geographic spread?
Well, breast cancer is the number one cancer if we look at women as a whole population in South Africa.
Right.
But the moment we start looking at black women particularly, then cervical cancer is the number one. And it then takes the place of breast cancer as the number one. And I think it is, I've got no evidence, but I think it is because of a lack of access to health care at a younger age. There are so many women living in the rural areas who have kilometers to walk to a nearest clinic where there will most probably not be the facilities for a pap smear to be done and to get the pap smear to a laboratory.
Right.
And even then, between the laboratory and getting the results back, many fall between the cracks.
Perhaps we should then try and tackle that question.
Yes.
Who's at risk of developing
I think firstly
cancer?
we need to understand that the prevalence in terms of age groups is a lot broader. It usually ranges from the ages of 15 to 45. We need to also take cognizance of the fact that our teenagers are certainly becoming more and more sexually active from an earlier age. So, the overprying parent or the teenager that is too awkward to talk about sexual health issues, that really has become myth and legend. So just to get back to the age group itself, it is a lot broader. With the advent of the HIV epidemic and with also the advent of the HIV and the ART program, women are living longer, but women are also presenting with more and more precancerous lesions and cervical cancer in their second decade or in their 20s. So certainly I do agree with Prof that the mark group from 30/40 has definitely come down a decade to 30/20. Absolutely, in 2009, there was a huge study done in KZN that already showed an 83% prevalence of cervical cancer that was detected in a cohort study. And these were particularly diagnosed in black women. And once again, it goes back to their lower socioeconomic status and the fact that they just get to their clinics a bit too late.
A bit too late, yeah. In terms of awareness, very quickly, last 10 seconds.
Well, I think we cannot do enough as far as awareness is concerned.
Yeah.
And I think the SABC is doing a wonderful work in a program of this nature. My only concern is, how do we get the message really at grassroots level in the rural and far rural areas to let those women and young girls especially, and we're talking cervical cancer, and I cannot let this opportunity pass. And I don't know whether it's going to come up later in the program, but the HPV virus is really spread by men. And I'm concerned that we don't vaccinate boys.
Right. That's our subject for the next segment. Well, Prof, perhaps, thank you very much for your time. Okay.
Thank you.
Time for a quick commercial break. After the break, we now focus on prevention and screening. Please stay with us.
MedShield Medical Scheme, we don't just talk health, we do health. SMS MedShield to 33023 or talk to your broker to get your kind of care. MedShield Medical Scheme doesn't just cover you when you're ill, we'll help you stay well. MedShield Medical Scheme, we don't just talk health, we do health.
Are you ready, Fairy? Come in. Hi, Fairy. Hello. I'm Dr. Feelgood. Nice to meet you. Nice to meet you, Dr. Feelgood. Excellent. What brings you in here today? I'm here for my first Pap test. Oh, wonderful. I'm so glad you came in. Thank you. Okay, so what we'll have you do is just spin around here. Okay. Want to get comfortable? Thank you. And bring your bottom down. Further. Oh, my bottom's not showing. Further. A little bit further, a little bit further. A little bit further in. That's good. Okay, you can just lay back and get comfortable. I'm just going to warm up the speculum. And the speculum is the instrument we use to get a good look at the cervix. Okay. And you're checking to make sure it's a nice temperature. Absolutely. We want to make sure that it's warm. Okay. So we're going to put the speculum inside. Just take a deep breath. And out. Relax. Alright. So the speculum's in. I've got a great look at the cervix. The next part of this is I'm just going to take a little brush, and a little brush will take a few little cells from the cervix. Okay? Thank you. Then we put the brush in a little container here. And the last part is just to relax again, deep breath, and the speculum's out. Everybody says that hurts, and you know what? It actually doesn't. Excellent. I mean, I can feel it, but it's not painful or anything. So we need to tell people, just get in here and do it. Excellent. Okay. Thank you so much, Dr.
That's how easy this pap test is. Now, before we start our discussion, I believe that we have Elizabeth on the line from Cape Town. Elizabeth, welcome to Health Talk.
Hi, good morning, and thank you for taking my call.
Your question or comment, please?
My question that I'd like to ask is, I'm 64 years old. Yeah. I do go for regular mammograms, but what I'd like to know, I've had a complete hysterectomy about 20 years ago, which means that both ovaries had been removed too. I get conflicting answers when I request whether I still need to do a pap smear. Fortunately for me, none of my immediate family has history of cervical cancer or cancer in any case. So I would just like to know for my own, do I still have to do a pap smear, and how often do I have to do that?
Just before you go, do you want to ask any question? No?
No, I could answer that for
thanks.
her.
You can listen, and we'll try and address your question a little later on, all right?
Thank you very, very much.
All right, thank you for your call. Yeah. Now it gives me great pleasure to welcome the First Lady of South Africa, Madam Thobeka Zuma, who is a founder and patron of the Thobeka Madiba Zuma TMZ Foundation. Welcome to Health Talk.
Thank you for having me.
All right. And of course, we still have Dr. Pam Pillay, specialist gynecologist based at Garden City Clinic in Johannesburg. Perhaps let's start with you, madam. Cervical cancer, I mean, obviously we're discussing cervical cancer. We've been discussing, cancers affecting women. The other time we discussed breast cancer. But just perhaps your views in terms of the need for prevention and screening. It may sound like an obvious question, but perhaps not. Your view, please.
My view is that there is a great importance in screening and the prevention of the disease, because women are dying from these largely preventable diseases. If only we had sound screening services followed by seeing and treating and a proper care and support in place, we'll see lesser women being diagnosed with the disease and lesser deaths. Right now in South Africa, we're looking at 7,000 diagnoses every year, and we're looking at 4,000 deaths, which is, for me, huge, because over 50% of the cases that are diagnosed with cervical cancer. And I think we need to strengthen our screening services. I listened to Professor Herbst when he was talking before the segment that, in the rural areas where my foundation focuses, the problem is access to screening on an equitable basis,
Right.
whereby even the settings in the clinic are not such that you can be able to conduct any pap smears. And therefore, it is important that our government strengthens our screening services, because then those cases can be detected early and those precancerous lesions can be treated and eliminated. So therefore, they wouldn't progress and become cervical cancer.
Great. Now, Dr. Pillay, we showed a clip of the pap smear. Let's talk about the rationale behind, what happens actually with the pap smear. What actually do you do there?
It is part of the routine gynae visit, and essentially with the pap smear, it is a crude screening test that is performed in the examination room. I think very importantly for doctors is to make their patients as comfortable as possible and as quickly as possible, because it is a very, very intimate part of a woman's body that is exposed. So during...
But you mentioned a doctor. Should it be done only by a doctor, or can a nurse?
It can be done by any healthcare professional who is qualified into doing proper pap smears. So the pap smear itself is a very easy test to perform, and one has certainly moved away from conventional pap smear testing to liquid-based pap smear testing, which increases the chances of detecting precancerous cells on that particular individual. During the test itself, it really is a very short, simple part of the clinical examination. The vagina is slightly distended with an instrument called a speculum, and thankfully we have disposable plastic speculums, which are much more easy for a woman to accept as part of her visit with her doctor, because the old conventional cold instruments tend to shy patients away. It really leads to their increased levels of discomfort. The speculum is passed through the vagina to expose the cervix, and a brush is actually used to smear the cervix. It's very important to actually try and get cells from inside the cervical canal for accurate diagnostics and reading.
But are there any barriers to pap testing? I mean, why aren't all young girls or young women actually doing this on a regular basis, do you think?
I think for me, the stigma associated with the disease, and the other myths that you're promiscuous if you get detected with the cervical cancer, and also the view that people still hold that cancer is a death sentence. So they'll rather fear rejection than death, because once they're detected with the disease, they get rejected even by the community and their families. So I think it is important, like for instance, my foundation looks at those gaps and educates our people about the importance and highlight the benefits that the doctor has outlined now of really getting screened and knowing your status and knowing where you stand as far as cervical cancer, especially in our country now that we're seeing the new HIV infection rate on the rise. We're looking at a week 2,300, and that we know that the human papillomavirus is, in the majority of cases, sexually transmitted during intercourse or vaginal oral, and that is why it's important for our people to be screened. But also on the prevention side, it's very important that we vaccinate our young girls that are sexually naive.
We're going to talk about vaccination a little later, but let's get back to Elizabeth. Elizabeth had a question around whether or not she should continue doing
64-year-old lady who's already been hysterectomized. Usually from the age of 64 on, in a woman who's had a hysterectomy for a non-benign lesion, for example, cervical cancer, then yes, I would definitely recommend annual to 3 yearly smears of the vagina, vault especially, to screen for cancer, because cancer of the cervix is also associated with vaginal cancer due to the same pathogen, which is HPV. However, if she's been hysterectomized for a benign lesion that was not at all related to cervical cancer, then she does not need to have follow-through smears at all.
Okay. Now, let's remind our viewers again in terms of who must do a pap test, at what age, and how often.
At the moment, our local government necessitates 3 lifetime smears, which I believe is a necessity and not an option. And that is a woman who's in her 30s, 40s, and in her 50s. Ideally, though, a woman should have annual pap smears within a year of her sexual debut, and 3 yearly smears to follow if the first 3 smears were reported normal. That is in keeping more with American and UK guidelines and strategies at the moment.
Okay, I believe we have another caller on the line, Gerald from Broncos Bay. Good morning, Gerald.
How are you, doctor?
Good, how are you? Your question, please?
I'm fine, man. Actually, like my mother actually is having a cancer. They diagnosed me the stage 2, but we're experiencing the problem at the government hospital. There's a delay that actually like that happening, and then the thing that actually spreading at the moment. So it's very much disturbing, actually, guys. So I think actually they have to improve actually the way actually they're working with the cancer actual patient.
All right. Okay. Thank you very much for your comment. Do you want to respond?
I didn't quite get the question.
I didn't quite get the question either.
It was a bit not very clear, but we'll carry on. Anyway, Gerard, are you still there? Oh, he's gone. Okay. I'm afraid there was a bit of a disturbance and I couldn't quite get what he was saying. But if you can, Gerard, please call us back and clarify your question. All right. Let's get to the issue of the pap smear, as we call it. Is it uncomfortable?
Not at all. I still go back to the fact that doctors do need to pay attention to their patients. Right. Even though a patient may have a long-standing relationship with her doctor or her health professional, I think every visit needs to be guided along the lines of empathy. Okay. And once that is in place, it usually becomes a less uncomfortable experience year after year after year. And I generally get that expression on patients' faces.
All right. I believe Gerald is back on the line. Gerald?
Yes, it's me again.
Yeah, you were saying?
Yeah, doctor, we're experiencing the problem actually when to come to this actually like a cancer patient in a hospital. Yeah. So there is a delay that actually like it's happening since actually like my mom was diagnosed with cancer 3. Yeah. There is no any progressing that doing. They're just postponing. They give the date because they're supposed to do the chemo now.
I see.
Since January, actually, there is a delay. They say actually like there's a waiting list.
Okay, all right. We'll respond to your question, I think, in one of the segments. So if you just keep glued to your set, we'll definitely answer your question a little later. Correct, Dr. Peter?
Absolutely.
All right. Let's just go for a quick break. After the break, we're now going to be talking solely about HPV vaccinations. Please stay with us.
Embracing our members in good health since 1968. Shield. Embracing our members in good health since 1968. SMS MedShield to 33023 or talk to your broker to get your kind of care.
Breast and cervical cancer are the 2 leading cancers amongst women in South Africa. About 82% of deaths due to cancer occur in developing countries where access to prevention services such as education, the HPV vaccination, screening and early treatment is limited. HPV greatly increases the risk of cervical cancer in women. Thankfully, the HPV vaccine is now freely available in the public health sector in South Africa. In 2014, 16,500 schools were visited and nearly 420,000 9-year-old girls were vaccinated against HPV. The department is encouraging all parents and caregivers to cooperate and allow their children to be vaccinated. According to reports, the most common side effects of the HPV vaccine include swelling, redness and pain at the site of the injection and headaches. The good news is that these are generally tolerable and short-lived. Cervical cancer usually does not have symptoms until it is quite advanced. For this reason, it is important for women to get regular screening for cervical cancer. Screening tests can pick up changes suggestive of early signs of the disease. This enables these early changes to be treated before they turn into cancer.
I've got a great look at the cervix.
Welcome back. Before I introduce another special guest who's joining us, let's take a call from Pretoria, and this is Chi on the line. Chi, welcome to Health Talk.
Thank you very much, sir.
Your comment or question, please?
I just needed to find out. I went to see my gynecologist earlier this week to discuss my results, which were low-grade intraepithelial lesions. And I was advised, to take 6 months to go think about it, whether I want to do a cone biopsy or an TAM. And obviously, because I'm not very clued up about the disease, I just need to find out from the doctor that, what would be the best step to take.
All right. Thank you very much for your question. Fortunately, we have a specialist next to us who can take such questions. But before you answer the question, let me introduce and welcome one other special guest that's joining us now, Martina Mutaung. Yes, we share the same surname, yes. Martina is the volunteer coordinator and goodwill ambassador of the TMZ Foundation. But she herself has been diagnosed with cervical cancer, among others, and she's going to share her experience with us a little later. Welcome to Health Talk.
Thank you so much.
All right. And of course, we still have the First Lady of South Africa, Madam Thobeka Zuma, and of course, Dr. Pam Pillay, specialist gynecologist based at the Garden City Clinic. Now, Dr. Pillay.
Answer to that question.
Please.
It depends on the patient's age, firstly. So the recommendation is that if the patient is under the age of 25, and if an HPV test can be simultaneously offered to the patient, it should be done. If the HPV result is is back with the reading of high-risk HPV being detected, particularly strain 16 and 18, then definitely one should proceed with colposcopy and biopsy of the cervix.
Okay. All right. Let's hope that she's listening and she'll take the advice. Yeah. Okay. Let me, at this stage, invite some comment from Martina. Martina, I believe that you have been diagnosed with cervical cancer.
True that.
Do you mind just sharing that story with us? When were you diagnosed?
Thank you so much. I was diagnosed 2006 because I had a lot of complications, abnormal bleeding, abdominal pains, and a lot of discharge because I'm a chronic patient. I'm an HIV activist, and I see that as a value to me to go to the doctor to frequent to check up. But when I go to the doctor told me that he sees nothing. Then the problem is that I was seeing the blisters on my private parts. So being scared that they might be coming out from inside. Then I request the doctor to do a pap smear. And
do you mind telling us how old you were at the time?
Yeah, I don't remember.
Okay, that's fine. But it was 2006.
Yes.
Yeah, all right.
Then he conducted the pap smear and do sauna to verify do I have those blisters inside. And due to the problem that I was bleeding abnormally during my menstruation time, then he told me that I must come and get the results in 7 days. Surprisingly, he phones me after 4 days and requests to see me very urgently. Then I went to the surgery and then asked, is there anything wrong? Then he says, yes, you are in stage 4 of cervical cancer. So I never had any information, and I never thought I'll get cancer at this stage, because what I know, I only had TB and HIV, and cancer was more heavy than HIV and TB. Yeah. Then he requested me to go to George Mukari the following day, because I remember it was Thursday. The following day I went to George Mukari. George Mukari, the doctor attended me very urgently, so then they conducted a biopsy. I think they've done biopsy three times, and they say the cancer was on the mouth of the uterus. Right. Then after the third test, that's where they say they no longer see anything. Mine is just to continue to take to do pap smear every 6 months, because I'm a chronic patient. having HIV, you need to frequently do it twice a year, not once a year, like a person who doesn't have chronic. Then that's where I was saved.
Let me ask Dr. Pillay to just clarify something. She just now she said stage 4.
Yes.
Do you want to just clarify that?
Staging of cervical cancer is a clinical one, so it needs to be done by a gynecologist who is in the know in terms of stage 4, diagnosis of cervical cancer. That usually is not possible without doing a biopsy of the bladder and without confirming that there are no metastatic lesions outside of the pelvis, specifically to the lung and to the liver. So stage 4 would be extremely difficult to confirm just purely by clinical staging, but it's not unheard of course. There are women who will present with marked spread of the cancer down to the lower 1/3 of the vagina, infiltrating the bladder, infiltrating the rectum, but usually it has to be supported by additional tests that need to be run.
So in her case, I mean, she's had three biopsies. What's the likelihood?
3 biopsies is not necessary, firstly. 1 biopsy is sufficient for the diagnosis. Unfortunately, the cervix can be so necrotic and so ulcerative that very little of the cancerous cells may be detected by just a single biopsy alone. The only place really for multiple biopsies is when we are in theatre doing a colposcope and biopsying the cervix then.
All right. So was it the first time you did this pap smear that time you presented to the doctor and asked her to do the pap smear?
No, it was not for the first time. I used to do it once a year.
Right.
But after being infected with HIV, it was for the first time. And I was diagnosed 2004. Yes.
Okay. And generally, how do you feel about the fact that you were diagnosed with cervical cancer?
It was so scary because of the way cancer was killing people, or it is killing people. But due to moral support, because what is more important is moral support and follow the right precautions, then you'll be safe.
Dr. Pillay, we left with about 2 minutes in the segment. Now, we need to talk about HPV vaccination.
Yes.
Okay, we have outlined the fact that, HPV infection puts people at risk of developing cervical cancer. Now, can you briefly just take us through the concept of HPV vaccination?
Okay. It has certainly been regarded as a sustainable development goal. So by the year 2035, it is expected to show its maximal impact on our herd immunity of little girls that we vaccinated in 2014 April. So 500,000 girls were put into a pilot project of mass vaccination school programming, and we're expected to see that maximal impact only, unfortunately, in the next 15 to 20 years, because it takes that long for a lesion to progress from a low-grade lesion into cancer itself. There are currently locally 2 available vaccines. One is the bivalent vaccine and the other is the quadrivalent vaccine. Both vaccines cover for the most high-risk strains of HPV, which are type 16 and 18. And additionally, the quadrivalent vaccine, sorry, little distraction there. The quadrivalent vaccine also covers for type 6 and 11 low-risk HPV strains, which are most commonly associated with anorectal lesions and genital warts. And that is when one should be looking at vaccinating males from the ages of 9 to 26.
Wow, that's another controversial one.
No, it's not.
Okay, before I ask the First Lady to comment, I believe we have Maki on the line. Maki, welcome to... Paki.
Thank you, Dr. Mutawunya. Yeah, it is not Mike, it's Paki in Cape Town.
My apologies.
It's okay, sir, with due respect. And good morning also to our panelists. Doctor, I just want to quickly, first before my question, let me quickly qualify my question to say I am not asking it out of ignorance. It's just that I'm asking it for just enriching my knowledge, obvious information, or also on behalf of others as well who might have such question. Seeing that the cervical cancer develops at that area, for people perhaps who may be engaging into sexual intercourse without protection, that is now without using condom and the like, what are chances of one being infected? My second question is...
Infected by?
Infected with I'm not sure whether is the cervical cancer, seeing that it develops around that area, you know, where the tests actually have been taken around that area when you're doing the pap what is this pap smear
yeah.
test. Yes, that is the pap smear. The samples are taken around the walls, around that area. For people who are actually engaging without protection, if a female is actually having such an illness, are there chances of this being transferred to the partner? That's one question.
Okay.
The second question, quickly.
We can only allow you one question, unfortunately, because our time is unfortunately very limited.
Okay, Doctor,
thank you very much for your question. Now, Dr. Pile, I think the question is around HPV infection and whether or not it's transmitted and that sort of thing, yeah?
I think the most important thing to take home today is to acknowledge that HPV is classified as a sexually transmitted infection.
Yeah.
And it is predominantly responsible for cervical cancer.
Okay.
And absolutely, the lack of barrier protection or the lack of use of condoms is definitely going to increase the spread and the plight of cervical cancer.
Okay. Last 30 seconds.
Yes.
Yeah. Your views on HPV vaccination and you know what the foundation is basically doing to try and encourage a lot more girls to be vaccinated.
The foundation supports the campaign, the Department of Health campaign, for the increased uptake of the HPV vaccination. As the doctors outlined that in 2014, around April, the vaccination campaign was launched by the Department of Health, working very closely with the social development as well as the Department of Basic Education. And the target then was 80% coverage of the public health schools and special schools. And what the government managed to achieve was 92%, that is just below 420,000 young girls were vaccinated. As of 2015, the government were able to vaccinate 356,230 girls going to public health schools, so in special schools. So I think as a country, we're doing very well because, as the doctor has also said, it's investing in the future. Right. We'll only see the results, you know, in 15 years' time, when the Minister of Health is faced with so many competing health priorities to save our people now and the problems that are tangible, as opposed to vaccinating the young girls. But at least we are content with the fact that we have a population of young girls that are safe from getting the cancer, although 70% protection, but it's still enough for us.
Well, First Lady of South Africa, Madam Thobeka Zuma, thank you so much for your time.
Thank you.
And of course, Martina Mutaung, Goodwill Ambassador, TMZ Foundation, thank you so much for your time. And I can only wish you well going forward. Keep up the good work.
Thank you so much.
All right, we'll go for a quick commercial break. After the break, we now focus on treatment and funding for cervical and other female cancers. Please stay with us.
It's so good, nothing else can replace just your slightest embrace. And if you only would be my own for the rest of my days, I will whisper this phrase, my darling, c'est bon.
At MedShield Medical Scheme, we don't just talk health, we do health.
Welcome back. I mean, we've spent quite a lot of time on prevention and screening, which is in fact even more important than treatment. But in this segment, we want to be focusing a little bit more on treatment. Now, very quickly, we don't want to spend too much time on treatment. what are the treatment options available?
It depends on whether it is true cervical cancer or whether it is a precancerous lesion. In the case of true cervical cancer, it depends again on the staging of the disease. Most patients in the early stages of cervical cancer will actually get away with a hysterectomy, which is usually considered a total hysterectomy of the uterus and the cervix.
So total removal of the uterus and the cervix.
Yeah? That is correct. In a young woman, it is important to do preserving of the ovaries, and that is just something that most doctors do need to take into consideration. The add-on benefits of chemotherapy and radiation usually will apply for lesions that are staged, or for cancer itself that has been staged from stage 2+ onwards.
Yeah. So essentially being diagnosed with cervical cancer isn't necessarily a death sentence. There are treatment options available.
Not at all. The 5-year survival rate for successful hysterectomy without comeback lesions is at least 90 to 95%, which compares very favorably with the US and the UK at the moment.
Right. Let me take this opportunity to welcome another special guest onto this program. Now, this is Dr. Stanley Molwabi. Dr. Molwabi is Principal Officer of MedShield Medical Scheme. Welcome to Health Talk, Dr. Molwabi.
Thank you for inviting me, Dr. Sir.
Right. We have you here because we're talking now treatment. There's a perception that medical aids don't want to pay for treatment of cancers affecting women.
Well,
can you dispel that myth or just confirm that in fact it is true?
Well, it's an unfortunate perception. The truth is that medical aids in general, particularly specifically at MedShield, we do pay for cancer. The controversies usually arise when the clinicians and the clinical protocols that are inform funding with medical schemes, where there is a discord. And then you find that a treating doctor wants to use a specific type of treatment regimen and maybe has not followed an algorithm which is best practice. And then there is a decline of funding.
Maybe let's focus on that a little bit more. I mean, because for instance, when it comes to breast cancer, so you explain this algorithm business, and we know that in medical aids, there's various options and so on. So is it that the more expensive medication is reserved for the rich options?
No, certainly not. An algorithm is basically a step care approach, where basically as clinicians, there is clinical protocols which basically say you start with a certain type of treatment regimen. If it fails, then you go to the next one. And just because we have to be cost effective in whatever we do when we treat people, you find that usually it's the more cheaper treatments at the beginning, and then as you go on with the protocols and the step care approach, treatment becomes more expensive. So in general, it's not about who pays what. It is usually what the stage of the cancer or the treatment regimen dictates in terms of cost.
Okay. Now, I mean, here we're talking treatment, and clearly as a medical aid, you wouldn't want people to get to that point where there's a need for treatment. So as a medical aid, what do you do to try and prevent cancer?
A lot was said about screening earlier, and definitely we cover screening of all types of various types, let me rather say. Specifically with cervical cancer, we do pay for pap smears, and to encourage people to actually do screening. That payment usually comes out of what is called risk. And basically what I mean is that usually you are allocated a certain number of visits to go to the doctor. When we pay for screening, we pay it out of the risk so that it doesn't affect the number of visits that you are entitled to. So that's the way medical aids encourage screening. So it is important that members who are on various medical aids make use of those benefits for screening.
Okay, so essentially you do pay for screening and for treatment.
We do.
All right, well, Dr. Stan Molwabi, Principal Officer of MedShield Medical Scheme, thank you so much for your time. Dr. Pempile, Specialist Gynecologist, Garden City Clinic, well, thank you very much for your time. It's been very, very fascinating discussion. Well, unfortunately, that's all we have for you today, folks. Remember that you can join us again next week on SABC News, and please remember to share your views and comments with us via our Facebook page, SABC Health Talk, and follow us on Twitter at SABC Health Talk. And remember again that this show is going to be repeated at 2 o'clock this afternoon, then again on Thursday morning at 5 a.m. I'm Dr. Solomon Down. Thank you so much for those calls, and please do take care.
If we're talking health, then let's talk seriously.
Win a brand new Kia Picanto with SABC TV license.